chatted with him for quite a while before lunch, and I think you're going to be absolutely as fascinated as I am. So I have Dr. Palmer.
Thank you very much. Thank you. You're welcome. So thank you for coming to join us for this presentation. I'm always a little bit apprehensive at starting a presentation at a conference that I've not been to before. I've not been to transpersonal psychology conference before. Because I never know what to expect from the audience. And most of the conferences I speak at, it feels as if I'm Daniel stepping into the lion's den, because I'm usually speaking to skeptics who find it very, very difficult to accept and believe what I'm telling you. I've got a feeling that's not going to happen today. I hope not anyway. So let me begin by asking you, let's see a show of hands. Is there anyone here who does not know what a dissociative disorder is? Dissociative identity disorder. So you're all familiar with the term, okay? Good. So I don't need to go into a great deal of detail explaining what it is. But just to remind ourselves, according to ICD-10 and DSM-4, I'm not up to date with 5, so forgive me for not bringing it fully up to date. According to these manuals, these are how dissociative disorders are defined. The etiology of DID is formerly known as multiple personality disorder, which I'm sure you're all familiar with that term. The name dissociation was derived from the French psychologist Pierre Janet, who described it as the disaggregation of personality, and that became translated into the English dissociation of personality. So as far as researchers and clinicians and experts in the treatment of dissociative identity disorder are concerned, Pierre Janet is the earliest psychiatrist who identified the condition as a mental disorder. So the treatment of dissociative disorder involves the reintegration of the dissociated subpersonalities. And in order to reintegrate them into the core self, they need to be recognised and discovered that they exist. So that's the first step, the discovery and recognition of the created subpersonalities, how they were created, under what circumstances, and how they are affecting the overall behaviour of the patient. So we need to be able to enter into dialogue with them to understand their objectives and wishes, and they need to be treated as an autonomous individual. The original traumatic experience needs to be reframed so that they can look at it in a slightly different way in order to help them with the process of reintegration. And the energy of that traumatic experience needs to be transmuted, distributed, resolved. Because every human experience, every human emotion has an energetic frequency. And destructive emotions have destructive energetic frequency, and that needs to be transmuted into something positive before the reintegration can proceed. And then there needs to be an agreement. All the dissociative subpersonalities, each one of them needs to agree that reintegration is going to be a good thing for them and for the personality as a whole. So now we get to the problems then. that's the objective. That's how it's supposed to work. But it's not that easy, is it? Because we get patients who are aggressive, resistant, and some of them are so ill that they can't communicate normally anyway. So how do we overcome these obstacles, these resistances? How do we meet these challenges? Well, I found in my experience, when working face to face with a patient, hypnosis is always better than dialogue with the conscious mind, because in the hypnotic trance, the subliminal self has far greater knowledge than the conscious waking mind. So I developed my skills as a hypnotherapist in parallel with my studies as a psychologist. And I always found that using hypnosis was by far quickest and easiest way of helping people with psychological problems. But the key to working with hypnosis is trust and an agreement. You can't hypnotise someone without their agreement. Actually, you can. I've done it. But then the moment they realise that their consciousness is shifted, they'll come out of it and say, I've actually had people say to me, I didn't give you permission to do that. So you can creep up on them and introduce them into the trance, and if they accept it, that's okay. But if they object to it, you're not going to go any further. So it requires trust and agreement. So if you don't have that trust and you don't have that agreement, what do you do then? Now we come to the easy bit. What I've learned, what I've found is the easy bit. But to take this step and use the easy bit does take a leap of faith, okay? And an open mind. And it's telepathy. Okay? Now, for any skeptics that may happen to be in the audience, I don't think we've got any today. But I'm recording this, as you could see, and I record all my presentations and lectures for the benefit of a much wider audience. Okay, so for those skeptics who are watching this, taking a leap of faith and open mind, I'd like to draw your attention to the teachings of J.J. Krishnamurti, the Theosophist, who said that a disciplined mind is not a free mind. And it's only in freedom that discoveries are made. And it's unfortunate that medicine and psychiatry, their thoughts are constrained by the discipline of those practices. They are very, very disciplined scientific minds. And it's very, very difficult for a person with such a disciplined mind to open up to the ideas that I'm going to be talking about. So it's just a bit of a warning, really, that there are going to be people that are not going to be able to accept these ideas. And recently I've been very, very fortunate in being presented with several cases that would probably be representative of the most difficult cases it is possible to find, to treat. These are cases where a family member has contacted me, a parent usually, on behalf of an offspring, a child, not a child, but a young person. And they seem to have common characteristics. These cases seem to be young men in their early 20s. And this is a case here of a 23-year-old, a good example of such a case. As I say, they have common characteristics, and I've grouped them together, but I'm just going to give one that represents this group of patients. Inception for hearing voices, psychotic behaviour, white Caucasian residing in Northern Europe, educated family, well provisioned, with no particular emphasis on religious practice, So just quite ordinary people going about their business, educated, affluent, intelligent. But they have a 23-year-old son that's still living with them. So that poses a question to start with, doesn't it? What's prevented this young man from leaving home and establishing his own life? When his behaviour became so unmanageable, they had to call an ambulance. He was taken into hospital. And it was whilst he was in hospital that his family contacted myself and my colleagues because they were not particularly happy at the way he was being treated in hospital. I'm not going to go into any details about their complaints, but they just said to me, can you help our son using your methods? So we had a go to see what we could find. And this is an ongoing case because none of these cases are dealt with quickly. The long-term damage that's been done to them is severe, and it takes a while for them to recover. It takes a while for the associated parts to be reintegrated. Now, what's interesting about these cases is that there's no contact whatsoever with the patient. There are two of us working. The interventionist team comprised of two practitioners. Myself, I'm a psychologist. I'm not mediumistic. I don't see or hear spirit at all. Okay? I am the scientist. And my colleague and partner is a medium. Now, he has a full-time job as an information technology software engineer. Again, it's just an ordinary bloke going about his business, earning a living. He works for a big company as an IT engineer. He's got a wife, a family, and a mortgage. Ordinary bloke. He's got this amazing gift that he can see and hear spirit beyond time and space. So I will contact my colleague, Andrew, his name is. He lives in the West Country. I live in Kent. And say, Andrew, got a case here. What is to help me with? And I'll give him the name of the patient, their age, and where they live. And that's all. I don't tell him what the problem is, because I don't want him to have any preconceived ideas. I just want him to connect telepathically, psychically, spiritually, whichever term you want to use, with that patient, and tell me what he finds. And he will convey to me what he perceives from his unique perspective and from what the spirit guides tell him. So all communications with the family are by email only. I've never spoken directly with a client or a patient, either by telephone or Skype or any other means, purely by email. So telepathy is the only communication used.